Yeah, very good evening to all. Uh, I think it's the first time I'm presenting in the Inform forum. So when Bala sir called, so basically this time I didn't make any presentation. So he told me to just give an overview or select a topic which I found to be very interesting. So I'll just share one of the topics, such topic that I found interesting in our day-to-day practice, and I'll go through how I came about ASDIN and what ASDIN presentations I've done in the past. So this is this year's ASDIN that we have gone, and you can see this is Hemant sir, Girish is there, and Suresh sir is here sitting with us. I've gotten to know sir since the first time I attended ASDIN, and since then, as Girish rightly said, he's like family to all of us. And as Girish presenting one of his presentation, getting an award, and Hemant sir also at the podium. So coming to a brief before I go on to the topic, vascular access is a challenge, and it's not something which is new to us. And it's a constant struggle between the patient and the nephrologist, especially when we have a problem. We need a well-functioning fistula, and then that gets into trouble and we have to salvage it. So it is a constant struggle all throughout. And we know there is one problem. The problem is that a patient requires a vascular access. You need a good, well-functioning vascular access. But the fact goes, one size does not fit all. So you have a variety of vascular access that we have to choose from. And probably the decision we do is what is ideal versus optimal. And in the process of this, when we strive to achieve that, we have to come to accept the fact that there is a vascular trade-off. One fistula might be chosen over the other, may not always be the ideal, but an optimal, and that might carry its own risk to the patient. And that one particular risk that we all are aware of, that vascular access causes cardiac dysfunction, and that is something which has been of very much interest to me earlier also. So surprisingly, and I was just fortunate that this year they covered a lot on fistulas in special group, especially cardiac patients and chronic hypertensive patients. And that's what I'm just picking up something some few key points I picked up from the speakers. And then I'll go on to high flow AVF should be closed after post-transplant. And of course, there was a hot debate on are catheters bad. So this was something which are very clinical, day-to-day practice, which we come across daily, and most of us have the answer. But here was a well set out with evidence, and it was a good discussion which I thought I should share. So we are all aware 50% of hemodialysis patients die because of a vascular access event, and chronic hypertension is associated with poor outcome. And it's very often that we find that there is a coexistence between chronic hypertension and intradialytic hypertension. And multiple studies have shown that AV fistula, as we call it as the lifeline for these patients on dialysis, represents a double-edged sword. And something which I picked up from this ASDIN was the term pathological situation. Our fistula creates a pathological situation where you have one part where it is required to continue hemodialysis and the survival of the patient. And on the other side, you know that fistula creates a hostile environment and has an adverse effect on the heart. So access maturation is a process that involves the entire cardiovascular system through a flow-mediated remodeling. So you have a fistula, and there is a varying level of cardiac remodeling occurring. And once a fistula is there, and if in case the fistula has a high flow rate with a patient with poor myocardial reserve, we are naturally going to expect the patient will go into cardiac decompensation. This further accelerates a heart failure, further hypertension, a setting of a chronic hypertension that leads to chronic vascular access thrombosis. So it is an interplay, and again the patient gets sick. So there's a strong connection between a fistula and its effect on the fistula that we create for the patient survival, which has a long-term effect on these patients in terms of cardiac mortality. So I'm not going into the full discussion of the topic. So I'll just take the key point at the conclusion of what was presented. So what is the axis of choice that we have in patients with a cardiac problem and chronic hypertension? Definitely, if the patient is fit for transplant, we work up and go in that line. Peritoneal dialysis is always preferred dialysis modality because it's a modality where we expect the least cardiac or hemodynamic instability. And given a choice, if you have to do a fistula, it is always preferred that we go with the distal radial fistula. And although we might have some concern in patients with chronic hypertension, will the fistula fail in the presence of, will a distal fistula fail in the presence of a chronic hypertension? But there is no evidence to prove or disprove that theory. And in case a brachial artery fistula is indeed created, we should always have it in the back of our mind and strict screening process that if the fistula becomes high flow, it can worsen the heart failure and hypertension. So always look, screen, surveil these patients for assessing the flow rate. And if you have a flow rate more than 1.5 liters per minute, consider flow reduction measures or other alternative. And when you come to a patient with poor life expectancy or you have class 4 disease, always consider a catheter-based access. So this is a chart and it is picked up from Roca's et al. Study, where when you have patients presenting with NYHA class 1 and 2, distal arm AVF can be safely done. In class 1, even proximal AVF can be done, but you have to keep a watch on the patient. Class 3 and class 4, it is preferred that we go with a tunnel catheter. The patient with poor LV function, less than 30%, a tunnel catheter, and those who come with life-threatening pulmonary edema or cardiac failure, go for a uncuffed catheter. So this is the basic principle of planning a vascular access for patients who come with a cardiac problem. Then you come across a patient who has an AVF fistula and develops a cardiac failure. Other than looking into our fistula, look for other factors, fluid overload, anemia, uncontrolled hypertension. If that is all ruled out, look for the access flow. If excess, and the target that we look for excess is defined as if it is more than 1.2 liters, then try for flow reduction procedures to target the flow to be reduced to 600 ml per minute. And what in case of those patients who have a high flow rate, but they are asymptomatic? There is no evidence to define what constitutes an excess flow in these patients. So basically it comes to the principle of preventing the disease rather than treating once the disease has occurred. So basically put on these patients with a high flow, but they are asymptomatic as far as the heart is concerned. Put them on a close surveillance with 6-monthly echocardiogram. Then the next a related topic in the same heart and fistula was, what would you do when a fistula following transplant? So to make it very simple, although this was a debate, I think the consensus was continue to keep and maintain a non-problematic AVF access after kidney transplant. But if you have a patient has a vascular related problem following the transplant, it could be a steel infection, then that has to be closed. But you have a patient who's asymptomatic as far as AV fistula is concerned, and if the flow is less than 1 liter per minute, you can unlikely that will cause a cardiac deterioration, so it can be preserved. If you watch out for fistula, if the flow is more than 1 liter per minute, because there is a high chance for cardiac failure. And if the flow is greater than 1.5 liter per minute, then likely that it's going to cause a cardiac failure and they should be ligated. Now, this is in the case of a patient with a stable kidney function. Now, in case you have a patient with unstable kidney function or has a varying degree of dysfunction, or you're suspecting they are going to progress to end stage, going to progress to severe renal dysfunction, then, and if their blood flow is more than 1.5 liters, do not close the fistula, but consider, definitely go ahead with banding procedure or flow reduction procedures. To just conclude my overview of this year's ASDIN was another thing which came up was the surfacer. It is something like Girish had presented earlier, was his out to inside method for managing patients with central venous thrombosis, long thrombosis. And this was some device which was something new which I picked up in addition to we hearing endovascular AVF or the hero graft, was where you go from outside inside, from out to in process method of cannulating a vein with a central vein stenosis. Now coming to the last part, so because I didn't present this time, but I have done presentations earlier. So my journey to the international forums for interventional nephrology started with in 2014 when I attended Hemant sir's first workshop in Mumbai. Subsequently, I joined ASDIN in 2015 and have been regularly attending most of the ASDIN's conferences since then. And it has been always a great experience learning something, meeting wonderful people. Suresh sir, I meet each time, and he has been very encouraging. I've attended most of their workshop. And initial period, I was a physician in training, and I got scholarship for abstract presentations also. From there, I got exposed to Vascular Access Society in Europe and Journal of Vascular Access, and got affiliated with them. And then, of course, we have the Indian group Avatar and INForm, which we all have to admit has been highly effective, a daily go-to basis forum for all our problems. So there were multiple presentations I have done in the past at ASDIN. And in particularly, I'll just go through one of my first presentation, which happened to be my first visit to ASDIN in Orlando itself in 2015 when I did my first poster presentation. And 8 years later, I'm getting my FASDIN from Orlando itself. So this was an article on a paper on my AVF maturation and role of nitroglycerin. So as you know, it is paramount that we have a good fistula. And what is essential for a good fistula once it's created is that you have a good blood flow, you have an adequate vasodilatation, and you have a very conducive endothelium. So what happens when a fistula is created? There's a cascade of events when blood flows from a high flow system, from the arterial system into a low capacity system, the venous system. So there is an increased arterial and blood flow. This increases the arterial and venous shear stress, increases nitric oxide, which causes further arterial and venous vasodilatation. Once there is further dilatation, that increases the flow, and that leads to medial hypertrophy and that so-called arterialization of our vein. So what happens in the scenario when you have a low flow and poor shear stress? This leads to neointimal hyperplasia, and this constricts our vessel, and that leads to failure in venous dilatation and long-term stenosis. So what we postulated here was using nitroglycerin, which mimics the action of endogenous nitric oxide by releasing nitric oxide. It directly acts on the vascular smooth muscle and causes vasodilatation. It inhibits platelet aggregation and inhibits leukocyte endothelial interactions. So basically, this was a double-blind randomized prospective trial. We had two groups. And the study was done, the baseline was assessed after 24 hours after a fistula was done. We only used radiocephalic fistulas. And we had two groups, one group which received a placebo patch, which a normal plaster, and the second group which received nitroglycerin patch, which released 5 mg over 24 hours. And both was applied for 24 hours, and then we reassessed the Doppler parameters. So I'll just go into the most relevant portion of the study, which basically shows what was the percentage difference between the Doppler indices between the two arms. So there was definitely, we looked at the arterial diameter, the arterial peaks, PSV, the venous diameter, venous peak systolic velocity, and the flow volume. So definitely the study showed that both in the placebo arm and the nitroderm arm, there was an increase in the arterial and venous diameter and including the flow volume. So you can see the arterial, but compared to the placebo arm, you can see in the nitroderm arm, the arterial dilatation percentage increase was significantly higher, 7%. In the venous dilatation group, it was 6%. And you can see the flow volume in the placebo arm, definitely there was a 12% functional increase. But in the case of nitroderm arm, there was a 44% functional increase. And this is the graph showing that the differences in the increase in across both the groups. So to conclude, using a nitroglycerin patch, which was releasing 5 mg over 24 hours, it showed that the Doppler indices increased 3 to 5 times than the study group. And being able to apply that superficially just over the anastomosis was an ideal area where a local drug could be delivered to the system to bring about a vasodilation. And when there is vasodilation, that increases the blood flow, increases the shear stress, and minimizes the risk of neointimal hyperplasia. So of course, this was just a study to show that will it cause an effective change in the initial period, which it showed. But then there was a plan to proceed with a larger trial to see whether the use of transdermal nitroglycerin in the has an effect on the long-term AVF maturation in terms of primary patency rate. Will the AVF mature faster? And of course, the dose of intervention. It is naturally expected that a single dose of nitroglycerin is not going to make much a difference, but it definitely had the effects that the hemodynamics changed in favor of a fistula that could develop faster. So this is one of the other slides, which I will just go these were more of a clinical case where we had a problem. So this is what about a distal tight stenosis. So this is a slide. So this is a patient with a basobasilic vein, lady. So you can see there was a distal anastomosis tight stenosis and a mid-arm tight stenosis. So we tried to, so this was way back in 2013. So, and it was a patient who we had, of course, limitation in terms of resources at that point of time. So we attempted a balloon angioplasty. We started with this, we decided to go ahead with the bare metal balloon mounted angioplasty. So we started inflating, and this was the best that we got. And we went up to 16, and we had to make do with this, and we deployed the stent, and we got out. For the gestate anastomotic stenosis, we tried to open it up with the same balloon because we had to use the same balloon, but it didn't open up. So what we did is on table, we went for a revision surgery and did anastomosis above the stenosis. Fistula went on well for 6 months and there was no issue. And then we had again a problem of a prolonged venous bleeding. And then we look at a check angiogram, venogram, and this is what we see, the stent has fractured. And subsequently, what we decided to do was we put in a PTFE graft. So subsequently, the case goes on that we had 2 more other cases where we had a long stenosis and we were in a resources being limited for those patients. What we did was for another patient, we again dissected out the stenosed portion and we used a graft. And in another patient, we used a patient's own great saphenous vein interposition graft. And so that is what we did for this post. So this is just a case approach. So when you come across a distal tight stenosis, of course, now we are using high pressure balloon angioplasty. And definitely, I would agree that we would not go to stent these patients in the distal aspect and lose a precious area, which is our cannulation site. And this was again one of the cases where we had a problem. And basically, this was a patient who came to us with a failed attempt on the right side, had a left internal jugular catheter, and then subsequently the patient was undergoing transplant. And we picked up a bruit in the supraclavicular area, and it showed that there was a AV fistula in that region, and angio shows that there was a abnormal connection between the thyrocervical artery and the internal jugular vein. So we decided to go endo procedure, and the radiologist had gone in and we ended up coiling it. Sadly, we started off with thinking we'll reduce it to 3 coils, but we ended up using almost 15 coils and became a very, very expensive procedure. Probably we should have just gone. So the patient was planned for surgery for transplant in a week's time. So we thought it was better to go endovascular and minimal issue. Probably if we had gone just an open incision, probably would have ligated that at a fraction of the cost. And to conclude, this was the first presentation I went in 2015 and the nitroglycerin patch. I got the first award at ASDIN, and subsequently from there, it went to Vascular Access Society in Barcelona in 2015 and then to Avatar also. Thank you.
Thank you, Dr. Paul, for the nice presentation. So we would open the house for discussion. So in the chat box, we have a question for Dr. Paul from Dr. Kashi Vishweshwaran sir. So Dr. Paul, Kashi sir is asking that what is the availability of nitroglycerin? What is your experience about the spray? And what are the cardiac side effects you found with the NTG patch?
So the nitroglycerin patch is readily available. So it was available in our cardiology pharmacy where we used to outsource it from them. It was only costing 60 rupees when we started off. So probably now price would have changed a little bit, 60 rupees and readily available. We didn't, there were a lot of exclusion criteria when it was concerned, when cardiac exclusion criteria. We didn't face any problem as far as the heart was concerned. There was no BP fall. We didn't have any issue with that. But except for one patient, since this was a locally applied patch, and we applied after, the reason why we chose after 24 hours so that there is bleeding settles and there is no edema also settles. One patient developed intense itching, so it causes intense vasodilation, and so that patient developed intense vasodilation below the patch area, that it became red, erythematous and intense itching. So it's kind of, the skin got burned in that area. We was using just one patch in hardly 12 hours. So then we had to exclude that patient out, and it recovered subsequently, but unfortunately there was a scar in that area also for this patient. But that was just one patient who had a problem. All other patients didn't have any problems, sir.